So, I am going to speak about something completely different. I'm going to talk about the need for good prevention and how we can achieve it. Saulus has spoken, Mika has spoken, you spoke also about, of course, of prevention of use of drugs, which is something different, but prevention for HIV and connected infectious diseases, STIs, etc. There has been a tendency over the latest period to think that testing and treatment would do the trick. The last high-level meeting in New York proved this is not so, that actually the drop of preventive services that have occurred in many countries have created a rise in new infections in certain parts of the population. So we need good prevention, and only then can the measures like testing and treatment also be effective. Some 10 years ago, we have to think about how does a prevention response look in a country. I can tell you about Sweden because I was the head of the national unit in Sweden. We had between 150 and 200 separate little actions going on in all over Sweden, in the cities, in the towns, in different parts of Sweden, addressing different target groups, doing different things. 200 every year, right? And this is the case in most countries. Prevention is not one giant program. It consists of many, many separate parts. And some 10 years ago, WHO started to scrutinize the preventive work in Eastern Europe. And they found that especially the health promotion and prevention relied very heavily on NGOs when it came to the most important vulnerable groups. And these organizations certainly knew very well what they should do. But unfortunately, the quality of their work was so uneven and unstable that it diminished the effect of their good knowledge and their possibilities. The concept of quality improvement, or quality assessment was not discussed. It was only discussed what we need to do, what is the evidence, but not how we do it in the proper way, all the time, systematically, every year, and all the 200 different interventions. How can we achieve that? That's a very interesting question. So, determining factors of success in health promotion prevention. That is that the chosen interventions, they must be the appropriate ones, and they must be carried out at a high level of quality, adapted to the context, because every context is specific. There is not two prisons that are alike if you want to do prevention. You have to have a program and then to adapt it. So this is the big thing. So a conference in Germany in 2008 that was given by WHO and the BCJ actually brought forward the knowledge that there are already actually tools, research, evidence-based methods on how to work with quality in health promotion and prevention in general. And they can be adapted to the health promotion and prevention of infectious diseases also. So, on that basis, there has been a project in Europe called the Quality Action. It has been going on between 2013 and 2016. And I was a part of this project, and this is what we aim to do. We wanted to increase the effectiveness of prevention by using quality assurance and quality improvement tools. And we had 45 partners from 22 European countries, also Lithuania. Saulus was one of our partners. And they were from public sector and NGO sector, chosen by the governments, and representing the 200 little interventions, more or less, you know, from different parts. The project has been evaluated by the Institute of Tropical Medicine in Antwerp. So I will now bring you some of the first results, actually. 105 people were trained to use the tools and to be able to help others to use the tool and train them. Altogether, 400 people in Europe were trained to use these tools, and 85 projects or government operations, small and large, implemented the tools and sent in some accounts of their work. So 105 were trained internationally, and another 300 people were trained nationally by the people who were trained in the first place. So that's why there are 400. And they were trained to use the 5 knowledge-based tools that actually we put forward. The work builds on, you know, the project process as we know it. The ideal phase of a project or a program is depicted in this picture. You plan something, you do something, ideally, which often doesn't happen, you check what you do, and then you act upon the results of your check. And by doing this, you become wiser and wiser, your work becomes better and better, and you roll the project up the hill. And what helps you roll it up the hill is if there are indicators and standards that are good, so that they can tell you what of the things you have done are good and should be kept. You know, you can see this little block under the wheel here. It stops the wheel from falling back. So you know what is good and that you should protect in your work. So this is the idea behind the quality improvement. And the standards and indicators that are used in these tools are based on research and reviews about what works. Success factors in health promotion and prevention. And through the research, they are then elaborated into different questionnaires and tools that you can use to check your own work. So I will just skip this. So these are the tools. There are 5 tools, of which 3 are published in scientific papers. Some are widely published or really well researched. Succeed, which is a tool that I helped to develop myself, is published in 1 scientific paper and also evaluated by the Swedish National Board for Health and Welfare. QUIP and PICA are based on tools that have been published a lot. So these are not just some tools that are, you know, taken out of some textbook somewhere, but they have been researched a lot. When you look at them, they might look simple. This is one of the problems of health promotion and prevention. We have to adapt our methods so that everyone can use it. All the 200 little projects need to be able to use the stuff, right? So we have to simplify and make the language simple. We cannot have Latin words that no one understands. That is not the aim of health promotion. The aim of health promotion is accessibility. So often health promotion becomes underestimated and people think it is banal. I can assure you, these tools are not banal. They are on a different level. Some are simpler to use, some need more time. I would, for Lithuania, what I have heard now, I would recommend PICA. It is a structured tool for people who work with intravenous drug users, for the preventive side of it. Because if you look into the research, there is a lot of evidence about harm reduction. Very little evidence of what comes before harm reduction. There is no scientific paper about HIV prevention information for people with drug use. We couldn't find one article in a big search internationally. So there is evidence and there is not. But these tools are evidence-based and they can be used. I would also urge the 34 youth clinics to use Succeed or Quip to look upon the preventive aspect of their work. Okay, everything, all the tools, all the materials, user guides, help you select the tool, everything you can find on the Quality Action EU website. These are the results. This is, the implementation projects by target group and by intervention focus. Yeah, you can see it. All kinds of preventive interventions and all kinds of target groups, and also the target groups that are most important, right? Factors supporting the implementation were found in the research. You have to find the right tool. You have to do the planning and preparation as recommended, or you will have problems. But it's all in the manuals. You can find it. You have to have the support of your organization to do it. And I don't know, did you translate the tools?
All of them.
All of them are in Lithuanian, and on the website you can find your own country, if it was participating, who are the contact persons. You can write to them and you can see if you have tools in your language. The tools take between 8 hours to 40 hours to implement, but planning and then doing changes is not included into this. But the actual process of implementing the tool takes between 8 to 40 hours. So 75 of the participants responded, and this is what they found. They did better targeting. They increased the reach of their interventions. And they got greater stakeholder involvement. 90% of the users thought that it was worth the investment. And I would like to conclude by mentioning one of these 200 little interventions in Ireland. It is a small testing site for migrants. They tested 15 people per week in 2 hours. They brought some of their clients and their collaborating clinic together, and they tried one of the tools. What happened? They found that they could be much more efficient by implementing a tablet where their clients could fill in their background. It gave them more information about the background, and they could increase their efficiency. They tested then 30 people instead of 15. The funders became so impressed by this result that they gave them more money. So now they are testing 60 people instead of 15 people by using 8 hours together with the clinic and their clients to look at their own work and see how they could improve it. So what you get from using these tools is maximum effect, extended reach and coverage, increased efficiency, which is what we need in prevention. It is possible, it's not very costly, you just have to dare to do it. I recommend you to go to the website and to talk to Salos and get the support to try it if you do preventive interventions. Thank you.